my office, we have 2 computers going.
I'm her big sister, so.
Okay.
Okay, you are now streaming live on YouTube. You can begin, Mr. Pisani.
Okay, Diana, would you go ahead with a roll call, please?
Okay, I'm present. Brett Stafford,
Present.
Mike Nolan.
Here.
Mike Nolan. He's not answering, but I see him. Raymond Peasany.
Here. Here.
Sheila Guidry.
Here.
Ken Alexander.
Here.
All right, and then also present, we have Dr. Ban. We have Mr. Alan Phillips, Phyllis Johnson, Patricia Wilton, Shannon Cyprian. Did I miss anybody?
All righty, we have a quorum to conduct business. All righty, we'll start off on the agenda. Are there any public comments?
Not at this time.
Okay, let's move to item 3 on the agenda, approval of the minutes from February 8th. Has everybody had a chance to review those?
So move to approve. Ken Alexander.
Do I have a second?
Second.
Second, Sheila Guidry. Any discussion? All in favor?
Aye.
Aye. Any opposed? Okay. We'll move on to the minutes of March 18th, 2021. Do I have a motion on the floor to accept the minutes?
I move.
Moved by Beth. Do I have a second?
Second.
Second by Sheila Guidry. Any discussion? All in favor?
Aye.
Any opposed? Okay, approval of the minutes has been accepted. All righty. Is there any public comment on the minutes?
Not at this time.
Okay, we'll move on to old business. Follow up on the revisions to the RT rules and regs. Dr. Collada, any status on that?
We are working on them, and I apologize that we're not ready, but we've had a few other rules ahead of you in the queue, and we continue to work with that. I hope to be able to send you something for final approval at the next meeting that you have.
Okay.
Back that up a little bit. Back up.
No, that goes in executive session. I'm sorry.
Oh, okay. There was something that had clinical lab and it had your name on it. So
Yeah,
it was like,
we'll take care of it.
got it.
All righty, we'll move on to correspondence regarding scope of practice. Question from Shelley Ponville. As you remember, at our last meeting that we had, we requested more information. The young lady called the LSBM office. She spoke with Dr. Collada. They reviewed the rules and regs. Then she followed up with a phone call to me as well on this situation. Basically, in my discussions with her, I asked her to put something in writing to the committee, which she has not sent it to me. And all she is wanting to do is just start IVs in this clinic. That's the gist of it, and wants to know if it's within the scope of practice of a respiratory therapist.
Technically, your rules do not provide for that.
And
The only time that I know that they provided is in the course of some diagnostics.
Yes, respiratory therapy diagnostic administrations.
Right. And outside of that, it's pretty limited. It's a pretty limited scope, if I remember right. It's,
Yes.
stress testing, some of those type procedures that require IV initiation by a therapist. But outside of those venues, we can't just go in and start an IV for somebody anywhere.
ER.
No, in the
In the
ER,
emergency room. It's come up before in the emergency room. Because they have therapists that work in an ER that start IVs
for
Well-
for fluid.
fluid administration only, no drugs, nothing else.
Right, so I would think, even if she's starting the IVs, a nurse or a doctor would have to hang the vitamins or whatever, but I don't have a problem with her starting them.
Well, let me say this to you. I think this particular request, you should out of hand reject as not an exception to your rules.
I agree.
Okay.
I agree with that. I think it opens a Pandora's box that you don't want to go to. There's one thing, I think Sheila's starting an IV in an ER for fluid administration, which is clinical, it's supervised, it's in that appropriate setting. But in an aesthetic clinic, to be able to hang vitamins in that type of outpatient environment, I think sets a precedent that could get ugly. That's personal opinion.
I agree, Ken. I don't think it ought to be done in an outpatient facility.
Not except in the purview of, if you're hanging fluid, if you're starting an IV in an ER, I don't have an issue with a therapist that has the skill sets and competency evaluated to do that at all for fluid, because that's going to go to homeostasis, cardiopulmonary, stability, et cetera, et cetera. So it's within that broad scope of RT of what we're doing from a cardiopulmonary status. So that doesn't give me any heartburn at all. But when it's for an adjunct therapy provision, for something on those lines, then has nothing to do with the provision of respiratory therapy or cardiopulmonary physiologic status.
Agree.
Yeah, I agree with that too.
Any further discussion? So what is the decision of the committee?
I would move that we reject the request.
We have a motion on the floor.
Second.
We have a second by Diana. Is there any further discussion?
Do we need to specify that it's more because of the site than because of the outpatient aesthetic clinic?
I think so, Diana, and also not Diana, Beth, and I also think that to stipulate that, hey, that the scope of practice allows us for the purposes of what without repeating myself, what I mentioned earlier, in the provision of something that was respiratory therapy related, cardiopulmonary physiologic status related, then it's appropriate. Outside of that window, it's not.
Any further discussion? All in favor?
Aye.
Any opposed? Dr. Van, y'all will craft a letter and send to this individual?
Yes, I will.
Thank you. Also in your packet, I included, if you didn't receive it, the COVID pandemic status in reference to respiratory therapists administering the COVID vaccine that was provided to us by Dr. Collada from April 7th.
Perfect.
FYI, I put it in your packets for review. All righty, is there any other old business that anybody would like to bring up at this time?
No, Mr. Chairman.
I'm sorry, Ken?
I said no, sir, Mr. Chairman.
Okay, is there any public comment at this time on any items discussed in old business?
No public comments at this time.
All righty. Let's go ahead and move on to new business. Phyllis, do you have anything that you'd like to present to us?
No, nothing new.
Okay, Shannon?
No, nothing new.
Okay. Dr. Van, how are things going with the pandemic with licensure? We're still doing the temporary?
Yes, yes, sir. We are still doing the temporary licensing. A matter of fact, I think I signed off on 2 this morning. I think that there, obviously with this surge, there's some people moving in now to assist. I do think though that what we will do is whenever this is over, I had originally anticipated that this might be end in November or December, but based upon what I'm seeing, I suspect this emergency will last until February or March at the earliest of 2022 and possibly longer. The state epidemiology people don't anticipate that this surge will peak until mid to late September. So I think we're going to be under emergency declaration a lot longer in that regard. But whenever, again, I'll reiterate, and you can pass this on to all the concerns that you get from your constituencies, whenever this is over, we will allow 90 days to have an orderly transition of care before we terminate all of those permits. Now, anybody can send us a letter saying, I'm moving out of town and we'll terminate the permit, but we will not terminate anybody's permit until 90 days after the emergency declaration is over. However, we will stop taking new applications the minute the emergency declaration is over. So there won't be any issues with new applications once the emergency declaration is over.
And are we still handling students in the same process as before?
Well, basically the issues with relating to students are they should be able to be tested now without any difficulty. They should be able to get their criminal background checks done, fingerprints done without any difficulty. I'd only anticipate any problems if the surge gets so bad that the state police stop doing fingerprints and or the testing centers stop giving the tests. Otherwise, I think we'll be in the same position we've been in without any difficulty.
Okay, thank you.
On the upside, though, the weekend numbers starting, I think, Thursday, Friday shows a little softening in that bacterial exponential growth curve. So
I hope you're right.
Yeah, if you look at the I don't know if you get those trend graphs and stuff, Van, but the that bacterial curve that went straight up is starting to, instead of seeing 40, 50, 100 admissions a day, we're seeing 15, 20 admissions a day. So it's starting to ebb. I'm just hoping that
let's hope it's not a notch and a real decrease.
Yeah, that's what and I said the exact same thing. Let's hope it's just, that's told my wife, let's hope it's not a notch. So now, Van, when the question about the use of paramedic in an RT environment, when is that, coach me on when that's an appropriate discussion point for us?
I think that's a new business. You can bring it up right now if Raymond will hear it for you.
Yes, sir. Ken, you can go ahead and bring it up.
Thank you. And to bring the rest of the committee up to speed. So, and I had a brief conversation Thursday with Dr. Van and an email exchange with Raymond about this. Had a hospital approach about using paramedics to adjunct their respiratory therapy staff. So, and for me, it was like, okay, I don't know the answer because it's I know they operate differently. So reached out and talked to Dr. Van on Thursday, same thing, basically paramedics work off of different, a telemed and then a radio control set of protocols with a medical director. And if they're out of that, they have protocols established with them where they can act independently, medication. And y'all are pretty much versed and they can intubate in the field. They can do other things. They can start IVs. They can do, they can do code medication. So they do a lot of the things that we do, a lot of those different things, except it's under a different protocol than when you're in a hospital and under different. So reached out to Bureau VMS, reached out to somebody that has expertise in those fields and had a conversation Friday, and then another one just prior to this meeting this morning. And essentially, there is a scope of practice. They work off the National Registry of EMTs. They're allowed within their protocols. So the question then becomes, it's like it's not indifferent then from what I'm learning, and I'm setting all this up for discussion, not as a definitive, that it appears to be not dissimilar to what a nurse does in a hospital that's also respiratory therapy related, that's within their scope of practice. So we license EMTs and paramedics and those paraprofessionals here in Louisiana. The rest of the country, most of the rest of the country certifies without a distinct license. Louisiana does license them through the Bureau of EMS. So they can work, from what I'm told, they can work under facility medical direction, the same as whether it's chief of staff. I would think maybe some education on the hospitals may be appropriate, but it seems like they can work and do those normal things. They can do on protocol, they can do breathing treatments, they can administer oxygen, their ventilator skills are very limited. They do rate and tidal volume on transport pretty much. And so they have a critical care certification specific, but it doesn't seem like it would reach into that. But as basic, floor care and the basics and the emergency response, it's within their scope. So that's kind of the setup, because the other piece is the staffing supplements the hospitals are receiving, if you're not in an active hospital, are from the federal government right now, from FEMA and HHS, to a large extent are paraprofessionals. They have some teams that come in with physicians, a PA, an NP, some nurses, but for the most part, they're bringing in teams of paramedics. So National Registered paramedics, so which do have a lot of those same skill sets, and they're putting them to run the monoclonal antibody clinics, and then hospitals are repurposing their staff to go back upstairs or whatever they're doing with them, or to adjunct staff in various clinical settings. They've got them in ERs, they've got them in med surges, and they have them in ICUs. Some of you guys may have them, Brett, you may have them in your shop. I don't know.
Yes,
Ray,
we have some in the ED for sure.
Yeah, and Ray, I know it through the Ochsner system. Ochsner's been using paraprofessionals even prior to the pandemic in some of their campuses. And so I throw that out to see, is there any do you guys have any heartburn, or for Dr. Van to say, okay, you need to make sure this is done, this is done, this is done.
Well, I think as long as they're not managing a ventilator, they could probably just about work anywhere we work. There's plenty of.
Remember that we don't license these people. They're licensed by a separate board.
Right.
And so we really don't exercise any control over them unless they move into the field of respiratory therapy. And so the question is, what do you want us to say is acceptable? And I think the question is that they generally have they usually have a combination of radio control and protocols. And now they're going to turn them loose in the hospital to do treatments. That's fine with us, unless you guys have an objection to it and how you want to qualify it, because we define what is respiratory therapy. And I just want to make sure we all understand that if you don't want them doing ventilators, then we could say to them, we allow them to do anything that they do under normal controls and normal protocols that are established in the hospital. And it can't just be, this is where it gets difficult. The chief of staff can't just say there's a blanket protocol. You can say there's a blanket protocol, but he's not going to be available for radio control. And that's when they supposed to operate with radio control primarily, and then protocols when they can't get radio control.
And they don't do critical care ventilation anyway. That's something that's very specific. But that even at a paramedic level, they don't do ICU level. So that's never within their scope of practice, from what I learned.
So when they go into the Ochners and work as a respiratory therapist, would they not revert to the manager of that department as the person overseeing them, deciding where they're going to work, what skills they're going to do?
They work under the physicians. From what I understand, Beth, is they work under medical direction. They work under medical direction, but it's not unlike we have independent use where we don't have to ask permission for every single thing. We know that we work under medical direction and under that authority. It's not dissimilar to them, but they have a different, everything they do, like if somebody craps out and they need to push a drug, they don't have to wait for a physician's written order to do that or call for a verbal order to do that. They have the ability under their protocol to do those things in the field, but they also have radio control tie back to a base camp somewhere.
Brett, how is that working out in your emergency department, and exactly what are they performing there?
Brett, you're muted.
I'm sorry, what was that, Sheila? You was asking about how's it working out?
Right, how's it working in your emergency department, and what
Give you a
procedures
whole
are
lot because
they performing?
it's not falling under me. It falls under our ED nursing director, but I know we have, we were already staffing EMTs, paramedics in there for assistance, and I think they just recently acquired some more. So like I said, all of ours that are in-house are being utilized in the emergency room area.
Which is
Push your staff out of the ED?
I'm sorry, what was that?
Did it push your staff out of the ED?
No, that's a negative. We still cover ED.
So they're using them more for
They're using them more for nursing aspect
Nursing,
and just
yeah.
short staffing and everything else because they can, come in and do a hodgepodge of different items.
Yeah.
but
We're not using them for respiratory or whatnot. They're using them for just the regular emergency department stuff.
Yeah. I'm not familiar in the OSHA system. I'm not saying it's not happening of anyone utilizing EMTs in the respiratory staffing, as well as Brett at my facility. I know they use them in the ER under the ED. Most of their triaging and helping assist in that aspect to free the nurse up so they can help with the patient, increased patient workload.
Yeah, and my understanding is when they're in the ICU environment in the state, from what I've learned, is they're being extenders. They're protected by the medical direction and under the not protected, but they're governed by the medical direction and everything, same as we would be or a nurse would be in those units, but used in those extender capacities. But I had a hospital reach out, and Beth and Diane, it's in your neck of the woods. It's intensive specialty hospital up there. So the LTAC.
Yeah.
So they were like the COVID capital. During the first couple surges, they had 100 patients in house. So they need some extender help for their respiratory therapy staff. And so they reached out and I said, I know they have protocols and those pieces, and the feds are sending them down ready to go. So, but I'll ask the question. So, and I tried to get myself educated. So I think Dr. Van said, if they're being used like they're doing in the other facilities or as extenders, it's, I don't think it's a problem.
I don't have a problem with it. Again, we're not talking about ICU and managing and weaning ventilators. We're talking about providing more hands on deck to give therapy and get oxygen started and
right.
And I don't have any problem with that. And
rapid response. I'm fine with rapid response. I mean, who better to show up for something like that than a paramedic?
Right.
But, they don't know enough about vents to manage these vents that we have. They have a simple transport ventilator they're working with.
Right.
The different modes of ventilation has significantly increased, and there's, so much more. It's complicated, and you have to be very knowledgeable of a lot of things.
Well, then I think to Dr. Van's point, we don't have governing authority. And I think the anecdotal, is just on case by case, is not blanketly say, hey, bring your paramedics to your respiratory therapy departments, but it's those questions to make sure that through the field that the word gets out that, making sure that they are not doing invasive ventilation management in an ICU setting.
So could we say something like, we don't have any problem with it as long as they are held to is it within their scope of practice?
Yes.
And then used in emergency response as opposed to inpatient management and therapy.
Yeah.
I think that'll give you what you need.
Yeah, well, I think emergency response, Dr. Van, I think they are going to use them for some routine like breathing treatments and those pieces to free the therapist up to work in ICU. I think
Okay.
it's what they're doing. Yeah.
Well, again, whatever y'all wanted to say, we'll go along with it.
Ken, if there's some way to put in there that as long as we're under this emergency declaration, what I don't want to see happen, and I don't think it will, but what I don't want to see happen is after we get through this, RTs can't get a job because they can hire the paramedic cheaper than they can the RT.
I don't think that's going to be an issue. Maybe if you had a little small rural hospital, but no, not in the major.
Well, I'm not saying it's gonna happen. I'm just, the last thing we want to do is turn over job responsibilities that can be capably handled. And again, we are in an RT shortage, just like they are in a nursing shortage. So I think this individual coming in and having some flexibility is good for those institutions that are running short and need it. But I just don't want to see, I don't want to create something down the future that says, oh, our paramedics can do this for a lot cheaper than an RT, and we'll just hire the RT for the ICU work and blah, blah, blah.
Right.
But again, who manages that is the directors of these departments. So
Yes, that is as big as say so. Yes.
I mean, I could see that potentially happening, them saying, oh, golly, this worked out well. Let me just hire paramedics and then we won't have to go to ER because they can do all these things. And then bam, all of a sudden you lose some RT positions because you don't have to staff ER.
But you don't have governance authority. We're not going to, that's a conversation that's immaterial to us at this point. We don't have the authority to say you can't do that, except where they breach their scope of practice. If they breach their scope of practice into an RT scope of practice, then you got a dog in the hunt. Outside of that fact, there's no, and Dr. Van, jump in and correct me if I'm wrong in any of this, you don't have a dog in the hunt because they're not governed and licensed by us.
I got a question, Ken. Did they talk about the different levels of paramedic? I know there's a national registry, which is pretty high in their education status, but there's a first responder, then there's a middle level, and then there's finally the national level. Did they? Yeah.
They all run under, yes, they all fall under the National Registry of Emergency Medical Care, whatever it is, NREMT.
Yeah.
They all fall under those. They all fall under that. The nationally registered paramedics are under that governing, kind of like our MBRC. So,
well, again, there's different levels, and I just want to be sure we're getting the top.
Well, it's paramedics. They're only sending paramedics. They're not sending the EMT intermediates, basic EMTs. They're not sending they're not sending those folks.
Because I know first responders do breathing treatments and oxygen therapy.
Yeah, under their first, the base EMTs, but they're not putting those in the hospitals.
Okay.
So I think I'm a little confused. So you're saying they're only wanting to bring in paramedics, not the EMTs?
That's correct. The feds, this is federally supplied staff.
I understand.
The feds are bringing in paramedics. They're not bringing in anything under that level that I'm aware of, Sheila.
Mm-hmm. So this would be we wouldn't be talking about local paramedics. We'd be talking about people that the feds are bringing in, like
Well,
they did that in Baton Rouge.
it's not a differentiation. You've got an emergency that John Bell's, the governor's emergency proclamations for accepting licenses from out of state. Okay. Goes for nurses, goes for physicians, goes for a bunch of different disciplines. So it extends also to the paramedics as well. I've got it on the printer. I didn't pull it back in, the proclamation that talks specifically to that discipline. And so, and my point today wasn't so much to open the can of worms, is just to validate and say, you know, hey, this is TransAlt. They've got to define, what I've learned is they've got to define scope of practice. They've got broad ability, same as a nurse, same as an RN does, and to a large extent, same as an LPN does, to do respiratory therapy procedures within their scope of education and practice. So within that, I'm comfortable because that's their lane that they're working in. But when it's, you know, when you're in that ICU environment, then I can see, and then the council's got to be, with my conversation back with Roseanne Pratt and Joe Cantor and others that are working these staff, and with the federal, Daryl, I forgot his name, the federal guy that's helping to bring all the staff in Louisiana, and also for the hospitals that are sourcing, they already know the drill. They've been pulling paramedics in the hospitals for years now, in different roles. So, and I think this is just a brief respite during the surge piece of this. And so I think the ICU piece was the only answer that really added context that needs to get articulated back.
Okay.
And to say, hey, if you don't want to get in trouble with BME or medical examiners, they don't need to be doing this. They don't need to be running ventilators in an ICU. Shy of that, there's not a whole lot they can't do.
Okay, so I would definitely disagree with them being in ICU. Number two, if they came in, say, to do NEVs, oxygen therapy, whatever is under their scope, which we don't have a copy of at this moment, say they went to Brett's hospital, they're already in his ER, and they decided they wanted to do floor therapy. And you're saying that they're under their own rules and regs. So would Brett have anything to say? Would he be in control of them if they're doing respiratory in his hospital?
Only to the extent as an employer, probably, unless they're employed by Brett, no. They're going to be held to the medical staff. They fall under the medical staff rules and regs, same as the respiratory therapist does. Respiratory therapy directors are there, you know, because the hospital put them there, but the respiratory therapists don't work under the director. They work under the medical director.
Right. So they could be in the hospital doing therapy and Brett doesn't even know they're doing it.
That's correct. And that's legal.
Yeah, it's legal, but how,
we may not like it, doesn't change it. You may not like that fact. Brett may not like that fact. Doesn't make it not happen.
Ken, I don't think it's a question of their scope. I think it's more of a question of who's managing. And managing, I understand they're under the direction of a physician, and it works real well in the ER because that's the
fine.
prima donna. But when you get on the floor, the doctors don't want to be bothered with that management skill. So would the institution assign them to Brett or whoever's
most of the, and understand that this was a single facility app. So I don't want to make a mountain out of this. Okay. No. So, it begged a question. It did beg a more global question, but without exception that I'm aware of, they are being brought in and they are being directed by medical staff and nursing staff. So they've been under, go ahead, Ray.
I will tell you that I did receive a text message from a very large system, not mine, inquiring about paramedics being employed in the respiratory department. And what was the board's stance on that? And I haven't got back to the individual on that. And again, just, you know, Sheila, and to your point, it's going to be whatever the organization's purview as to where they're going to assign these people, what they're going to do. We can only hope that, there's Joint Commission guidelines to follow, that, they go through an orientation process, a skills check off, and hopefully respiratory is involved. I think we just need to decide if there is a shortage out there, guys. It's anybody in the field, Brett can vouch for it. It's terrible out there. I can't keep up. I'm sinking,
Yeah, this is a different animal. I mean, it's a very different animal right now in working with the organizations. So they're grasping at straws. I mean, they are just tapped, and there is no room in the inn. So they're trying to find help however they can, but they're trying to find appropriate help. So the hospitals are. A lot of this, and this will self-correct at the end of all of this. Okay, medicine will look different, but it's going to self-correct. But they are all grasping at straws. The things that you've got, okay, the tools in the toolbox that are protecting the public, okay, are if Raymond in his organization saw a paramedic in his ICU, or Brett working on a ventilator that had no business working on a ventilator, then they can go to their administration and say that's an issue. Okay, if that administration didn't correct or do whatever, any individual can put a call into Department of Health standards and say, I think that I think I've got a hospital that's working out of their licensing capacities, because hospital licensure rules dictate how respiratory therapy is run in a hospital. Okay, the board we as the advisory committee advise the board of medical examiners on what things a respiratory therapist does and how they do them. But how respiratory therapy is organized and licensed and run in a hospital falls under health standards. So you can always put a phone call into health standards and saying, I got a complaint. And that instantly rises to a higher level of urgency for them. And they investigate that complaint. And if it's urgent, then CMS, it's an immediate jeopardy. If you've got somebody doing something in an unlicensed capacity, something else, you can always put a complaint into CMS, regional headquarters, for immediate jeopardy or whatever they feel. You put the complaint in, then they determine the severity of the complaint or the severity of whatever's going on. So there's checks and balances along the way in this.
And the hospitals are not going to put people that aren't competent in these roles right now, because these individuals are sick. They are sick when they hit our doors, and
right.
We're devoting a lot of time to patients, and some of them aren't being seen. So we need some resources out there.
Oh yeah, well that's kind of like today. I needed 13 staff. I have 7. Over the weekend, I needed about the same. I needed about 13, and I had 5. So everybody's struggling. It's tight.
Wow.
So we're having to rely on those particular situations this weekend. We wrote it down, we prioritize critical care and emergency services, and, got that information throughout all the nursing soups and everything throughout the house. They've been assisting with those floor patients and MDIs and that type of stuff. That's how it is now.
Sorry to create confusion, guys.
No.
Wasn't my intent.
Well, and I'm hearing what you're saying. If this came from the governor through emergency declaration or whatever, it likely will take care of itself when we're out of the woods, whenever that may be. And maybe we won't have the issue Diana was concerned about, that, the jobs will be lost to these folks. So, that would be I share that concern with her down the road.
They won't be lost in my facility. Now, like you said, I could see where maybe a small rural, 15, 20 bed hospital, maybe something, but not here.
And they're going to be, and they're going to be governed if they're not Joint Commission or D&B accredited, their CMS. For the most part, that if they take Medicare, if they don't take Medicare, they're like the specialty hospitals and those kind of, boutique places. Some of those folks don't take Medicare, and aren't accepted by Medicare. But if they're followed, then health standards is going to come into those facilities, and they better be following the licensure rules under, Chapter 93 for hospital licensing standards, respiratory therapy services. And if they're not, then they're going to have, that's a pop, and they're going to have to answer to that. So regardless of size, whether it's a critical access or a tier 2 or whatever it is, they all have, there's those governing kind of levelers that are going to do that. What, for me, the takeaway from this conversation is to make sure that the hospitals are aware that, hey, paramedics, yes, paramedics are great extenders, but they are extenders. And in an ICU setting, they're not trained to be independent ventilator managers. And I don't think you would find responsible individuals that would be willing to accept that responsibility anyway.
You never know.
No, you don't. As we found, even within our field, we've gotten folks that have stepped out of bounds. But
Well, Dr. Van, what do you think our approach to this should be? What kind of mandates can we put out there, or is there any?
Why don't you let Ms. Wilton and I put our heads together based around the facts that we accumulated during this discussion, and I will send that letter to you, Raymond, and you can discuss it with Ken. And I don't know that you need to convene anything. We're going to just basically put together a statement based around what you told us. If you approve it, we'll send it out. And if you don't, then we'll meet again and discuss it.
I move that we do that.
I second.
Any
So the
further?
motion is for staff to draft a letter based upon our discussion to be approved by Mr. Pisani and Kenneth, and then we'll send it out, or if it's not approved, they'll come back to you all.
And we'll just
Amen.
disperse it to everyone.
Hey, and Dr. Van, just a suggestion, not my, I don't have the ability to tell you what to do, but a call to Joe Canner, having a conversation with Joe to see if, get his thoughts on that too, because he's the one dealing with all the federal staffing folks.
Lately, we talk about 3 times a week. I just got off the phone with him at 9 o'clock this morning. So
Yeah, yeah,
I'll talk to him.
All right, thanks.
All righty. Is there any further discussion before we move on?
No.
Any other new business anyone would like to discuss?
Raymond, this is a new business, but as I'm flipping through here, just make sure I haven't lost my mind. Before you sign off on those minutes, they have us listed as the Medical Psychology Advisory Committee.
Nope.
Both of them.
And we may be mental, but we're not that.
Wait a minute, hold on a minute. I got to find that one.
Yeah, I didn't see that one either.
But above Raymond.
Yeah, I missed that myself.
Scroll down where Raymond's going to sign on both of the minutes. Right there, stop.
Okay.
Executive session meeting of the medical psychology.
I got you. Thank you very much. We'll fix that.
It's on both of them. And I wouldn't have seen it except the page was parked there a while ago and my mom was.
Okay.
Hey, great catch.
Good catch. Thank you very much.
I thought it was clinical lab. So yeah, you did better than me. That's what I caught it too.
We'll fix that. Thank you very much for calling it to our attention.
Friday. Thank you, Diana. All right. Is there any public comment for the new business that was discussed?
No, sir, not at this time.
Okay. Let's see. At this time, I'd like a motion to go into executive session.
I so move.
Second. Need a second?
Second.
Second by Brett. Any discussion? All in favor?
Aye.
Aye.
Opposed? Okay. Can we have the video stopped? The recording stop, rather?
Yes, we're gonna take,
Actually, yeah, the
Go ahead.
video is going to stay going in a public session environment. We're going to move you to a breakout room that's exclusively for executive session. Nobody else, except for the members that are present here, will be involved in that. So it'll move everybody over, and then when we're ready to exit executive session, you might get a little pop-up on your screen saying to leave room, and then you would do that and go back to public session. So we're ready to do that. I'm moving everybody over now.